So thanks everybody for attending our PoTS UK session today. The session's really suitable for those awaiting diagnosis or newly diagnosed, so it's very much kind of a PoTS for beginner session. Big thank you to our chair, Professor Lesley Kavi, for hosting it today. I don't think people would appreciate the amount of work that goes into the behind the scenes of running a charity, so it's very much appreciated for you to give up your time. There's loads and loads of information to go through, and there's quite a lot of slides, so hopefully there's going to be loads of content that people will find really helpful. As ever, it will be recorded and added onto our YouTube session, our YouTube channel, so you'll be able to refer back to it if there's anything you weren't sure about or you wanted to go over again. Dependent on the time, as ever, we tend to find that we don't get through all of the questions that we get asked. If you can pop them in the Q&A box, but perhaps wait till kind of towards the end of the session, because it may be that Lesley will answer your question throughout, then that would be great. Any questions that we don't get to cover, we will follow up with after the session. We'll either do a document answering them or potentially a recorded webinar that we can share if there's lots of them. So we'll keep you posted about that. There is a short survey at the end if you would be happy to complete that. It really helps us. It does quite literally only take about 2 minutes, and it's just an opportunity for you to have your say. So we'd be really grateful about that. We're always asked whether or not we're willing to share our slides, and these will be emailed out to everybody afterwards, so we will email those across. And I think that is everything. So I will hand over to Lesley now, and I hope everybody finds the session really helpful. Thank you. Thanks, Lesley.
Thanks, Jo. As we invited patients with a new diagnosis or on their journey to trying to find a diagnosis, I imagine this is you're also quite new to PoTS UK, and I'd like to welcome you to the charity as well. So today I'm going to cover what PoTS is, what causes it, how to obtain a diagnosis, how best to manage it, and what to do when things aren't going as well as you would like. So although PoTS was first defined in 1993 in North America, it's likely that it's the same thing that was described by Sir James Mackenzie in the British Medical Journal in 1916, and he called the condition the soldier's heart. And a lot of people aren't aware that this was actually the commonest, the second commonest cause of medical discharge from the British Army, and it was occurring in Europe and other places as well, and a lot of people suspect that most of these patients had something like PoTS, if not PoTS itself. In these days, they used to treat people with all sorts of poisons like digitalis, strychnine, extract of adrenaline, and bed rest. But Sir James Mackenzie took a different approach to this, and he recommended that his patients should have exercise. For example, fishing and golf and polo was recommended for the officers, and the foot soldiers were advised to play bowls and quoits, which is the game on the bottom right-hand side. So what happens when a healthy person stands up? Well, immediately that you stand up, a substantial amount of blood wants to drop out of your thorax, your chest cavity, and down into your abdomen and your legs. And in a healthy person, the blood vessels narrow immediately, and that sends the blood back up to the heart and brain. The heart rate increases a little, usually by 10 to 20 beats per minute as well. That's normal. But in a patient with PoTS, and in fact this often occurs in people with vasovagal syncope and orthostatic hypertension, the blood, as it drops down, the blood vessels are not able to narrow as effectively. And this means there's less blood returns to the heart races to try and compensate. It can't get as much blood up to the brain, and you produce increased levels of adrenaline to try and compensate. So why does this all happen? Well, to be honest, the medical profession doesn't fully understand it yet. There are four main theories. One of them is that it's an autoimmune condition. It often starts post-virally. There's people who have PoTS, they've got more autoimmune conditions than the general population. And there's increases in levels of autoimmune antibodies in the blood of patients with PoTS compared to controls. There's one family who've got PoTS in North America who've got a genetic mutation. It's thought that there may be some kind of abnormal response by the kidneys. Patients have, the volume of their blood is proportionally too small for their blood vessels, so they're called hypovolemic. And you would normally get raised levels of chemicals in your blood to allow you to compensate for that. But patients with PoTS have quite low levels of renin and aldosterone. And, you know, some people say that PoTS is due to deconditioning, but when we studied our patients, we found that 60% of them were actually having regular exercise before their PoTS started. So we don't think it's caused by deconditioning, but it's fairly clear from some research and from patient stories that when they do become, because exercise makes them so poorly, and sometimes people do become a bit deconditioned as a consequence of PoTS, this can actually worsen their symptoms. And these are the symptoms of PoTS. The commonest three are dizziness or lightheadedness, fatigue and palpitations. Patients often faint, but you don't have to faint to have PoTS. In the UK, 60% of patients reported recurrent fainting. The number's a bit less in for example, North America, and we don't know why this is, but I do wonder if it might be because you have to get into a clinic that sees people who faint to actually get the diagnosis because they know a little bit about it. And patients sweat, they get visual greying, they get shakiness, headaches, hearing disturbances, and patients often complain of brain fog or difficulty in thinking. There are a number of other symptoms that are reported by patients as well. So how do you diagnose PoTS? Well, first of all, the healthcare professional should really take a detailed history from the patient, covering symptoms, past medical history, family history, and things like that. On examination, there's often very little to find, but about 50% of patients develop something called acrocyanosis. And that means when you're standing up for a little while, your feet or your hands will go this sort of purpley, bluey, reddish colour, and sometimes they look a little bit puffy as well, and it disappears when you lie down. Patients usually need tests to exclude conditions with other symptoms. For example, you'd be checked for anemia, for an overactive thyroid or an underactive thyroid, and an ECG to look at heart conditions as well. Now, although previously the gold standard test to diagnose PoTS was thought to be a tilt table test, and that you had to have a tilt table test to diagnose PoTS, it's been, that some research has shown that you can get what are called a lot of false positives. In other words, healthy people can look like they've got PoTS on a tilt table and be misdiagnosed. And that seems to happen less often with the stand test. So some of the specialists are moving over to focusing more on the stand, the 10-minute active stand test rather than a tilt table test. And the tilt table test is actually very useful for ruling out other conditions. The 10-minute stand test is also called the NASA test, or some people call it the poor man's tilt test. And you lie down and rest for a while, and you have your heart rate and blood pressure recorded, and then you stand up and it's recorded for every 2 minutes until 10 minutes, or unless the test has to be stopped because somebody's very symptomatic or they faint. And this is what you see in a tilt table test. This is a printout courtesy of Dr. Raj, and you can see on the right hand side, this is the control, that when the tilt table is tilted upright here, the heart rate just goes up by about 20 beats per minute, And this is the blood pressure here, and it's pretty stable. Whereas if you look at the PoTS patient, you can see that here when the table is tilted up, the blood pressure becomes quite unstable and the heart rate goes up, in this case, up to about 190 beats per minute, but you don't have to have anything like as high as that to be diagnosed with PoTS. So the definition, this is an American one, is frequent symptoms of PoTS on standing, and this should be associated with an increase in heart rate of 30 beats per minute or 40 in children, teenagers, I should say. And this should be sustained. In other words, some people, their heart rate will go up when they stand, sometimes more than 20 beats per minute, but it often settles quite quickly, and that wouldn't normally be considered to be PoTS. By definition, there's no drop in blood pressure, but patients with PoTS can also experience episodes of vasovagal syncope, which can involve a reduction in both blood pressure and heart rate. Some of the commonest inquiries that I get at the charity from patients is sort of confusion, either on the part of the patient and not uncommonly on the part of their healthcare professional, about what diagnosis they actually have. And certainly in some types of orthostatic hypotension, or something that's called the vasodepressive form of vasovagal syncope, you can, as the blood pressure goes down, you can get an increase in heart rate, and this can be confused with PoTS, and then sometimes people get the wrong diagnosis. By and large, it probably doesn't matter too much, because the treatments for all three of these, on the whole, with one or two exceptions, are the same. So there are some conditions that are associated with PoTS, possibly causing it. The hypermobile form of Ehlers-Danlos syndrome, or hypermobility spectrum disorder, is the commonest one. Depending on which paper you read, about a quarter of patients with chronic fatigue syndrome have PoTS. It's found in Sjogren's syndrome, that's an autoimmune condition, and it's found in relation to mast cell activation syndrome or disorder. Patients often report that their PoTS started after a viral infection, such as the Epstein-Barr virus, which is also known as glandular fever. And as a charity, we haven't been at all surprised to find that a lot of patients are developing PoTS after COVID-19 infection. There have been case reports in relation to Lyme disease, multiple sclerosis, mitochondrial disease, and a number of other things as well. And that's the hypermobile form of Ehlers-Danlos syndrome, and you can see that patients they have possibly stretchy blood vessels. The actual relationship's not clear. Stretchy skin, they have stretchy joints. There's often a family history. They often have gut problems, and fatigue can be a very profound symptom. So there's quite a lot more information on our website under the What is PoTS section if you want to learn about this in a little bit more detail. So PoTS is commonly misdiagnosed, and in fact in the UK, the last time we looked at it, it took on average 7 years for patients to get a diagnosis of PoTS. And on their journey there, they're often given psychiatric labelling. In fact, in half of the patients, they were told that they had anxiety or a panic disorder, depression, hypochondriasis. Some patients with vasovagal syncope were misdiagnosed, and also patients are often told they've got CSF-ME, and it doesn't occur to people to look for PoTS. It's sometimes called an invisible disease because patients are often quite incapacitated by their symptoms, but they often look reasonably well. It's estimated to affect about 0.2% of the population, which is about as common as anorexia nervosa. And it most commonly affects women between the ages of 15 to 50, but that doesn't mean it can't affect children and older people too. The disability can be quite significant, and some people relate it to that caused by symptoms of heart failure, which tends to occur in older people, and chronic obstructive airways disease. 25% of our members were wheelchair users and 50% of children were off long term. However, once you get a diagnosis and you start the lifestyle management and sometimes medications required, the majority of patients will improve with treatment. And some will get back to their previous level of functioning, although the actual statistics for that vary from paper to paper. Another question that I get asked a lot at the charity is PoTS considered a disability in terms of the Equality Act 2010? And unfortunately, there's not really a single answer to that question. It really depends on how your PoTS affects you. Some people are affected quite mildly and some people are affected very severely. And basically, if it affects your day-to-day activities on a daily basis, then it's likely that it will be considered a disability. And this often comes up in relation to employment issues and benefit issues. Okay, so how do you treat PoTS? Well, the treatment is mostly based on the treatment that was developed for orthostatic hypotension. And again, there's a lot more information about how to manage PoTS on our website under PoTS management. We are currently updating the website, and there are one or two that are in process of being updated and not visible at the moment, but we'll get them on there as soon as we can. And we're also developing a couple of new pages as well. So first of all, you want to avoid anything that triggers your PoTS. And that might be medication that tends to lower your blood pressure, such as antihypertensive medicines. Some people are on amitriptyline for pain, and that can exacerbate symptoms in some patients. As a GP, I don't always stop it. I might ask them to try stopping it, and if their symptoms are no better, they can go back on it again. Prolonged standing and prolonged sitting can worsen symptoms and should be avoided where possible. Heat and alcohol dilate your blood vessels, and so they tend to exacerbate symptoms too. And then heavy meals that are very rich in refined carbohydrates, such as white bread, pasta, cake, biscuits. If you eat these types of food, they tend to divert the blood flow to your gut and away from your brain, and can worsen symptoms too. So we usually recommend that patients have a high fluid intake, and that should be 2 to 3 litres a day as a minimum, and sometimes more in a hot climate, or if you're exercising. It's important to try and count how much fluid you're having, because quite often people underestimate how much fluid they're actually taking. Your kidneys can actually handle about 1 litre of fluid per hour. And in theory, you should be able to drink 24 litres of fluid over 24 hours, but you can get waterlogged, and this can actually be very dangerous. So we would recommend that whilst you should have a boost in fluids before you get out of bed or first thing in the morning, where you tend to be a little bit more dehydrated, and then try to spread your fluid intake throughout the day, and not attempt to have something like 6 litres first thing in the morning, because that could make you quite poorly. With children, because of their different weights, we usually recommend that they drink fluids until their urine is a very pale straw colour. You can monitor your fluid intake. We have you can use the bottles that say have half a litre or a litre in it, so it's easier to measure. And there are a number of apps available that can also help you to monitor your fluid intake, and they give you a bit of a fanfare when you actually reach your target. Rapid water drinking is quite interesting. So if you drink 2 glasses of water in quick succession, then within just a few minutes of you doing that, before the fluid enters your blood vessels, patients with PoTS have a reduction in their heart rate, and patients with low blood pressure have an increase in their blood pressure. And that's thought to be due to a sympathetic reflex. When the stomach gets stretched, then it raises your blood pressure and lowers your heart rate. We usually recommend increased salt in the diet. It's not suitable for everybody. People with conditions like heart disease and kidney disease shouldn't have this, and you've got to be very careful in children as well. It's not that they can't have it, but you've just got to only do it under medical advice. And if you're having extra salt in an adult, we would normally recommend about a level teaspoon extra per day. And that's equivalent to 10 slow sodium tablets. With smaller children, then there is a formula that you can use to work out how much salt you should have in relation to your body weight. So regarding diet, patients tell us that there are a number of measures that have been helpful. Obviously, the high salt I've mentioned. Patients find that eating little and often, maybe half-sized meals, but 6 times a day is helpful. Patients have low gluten, paleo diets, plant-based diets. People with mast cell activation report low histamine diets. Eating when you're lying down can relieve some of the gut symptoms, and so on. Unfortunately, there hasn't been a lot of research to back this up yet. And so it's very difficult for us to be able to tell individual patients what type of diet would actually suit them better. And you know, more research really needs to be done in this area to work out what's best for which person. And if you are trying any of these diets, you know, sometimes people can try several different things and they can end up with very elemental diets and lacking in vitamins and things like that. So if it's going to be something you're doing for a wee while, you probably ought to get advice from a dietitian about it. So it's important to pace your activities, and often if patients aren't feeling well and they have a good day, they try to fit too much in and make the most of it, but that can knock you out for a few days afterwards. So try to pace your activities at a regular and manageable level. Regarding exercise, it does seem to be helpful in the majority of patients with PoTS. The situation in patients who've got PoTS and chronic fatigue syndrome is not clear, and that needs to be further researched. If you are exercising, usually if you've had PoTS for a little while, you need to start at a very, very low level of exercise. And I would say that you would need to wait a minimum of 6 weeks to notice the difference, and it can take even 3 to 6 months. And a lot of patients do feel worse before they start to feel better. Other sorts of exercise that can be helpful in PoTS are Pilates, which does core muscle strengthening. Swimming's often recommended. Now, with swimming, a lot of people struggle with swimming, and it's often not the swimming that's the problem. It's actually getting out the pool, getting dressed in a hot changing room, having a hot shower afterwards. So if you're finding that that's an issue, rest at the side of the pool till your heart rate's settled, maybe sit by the side of the pool for a wee while, have a cool shower, and just have everything ready if you find that the heat in the changing rooms affects you, just so that you can get out as quickly as you can. Recumbent exercise, biking and rowing has been recommended. And then the target would be that you would then move on to more upright exercise, such as brisk walking if you can. Compression has been recommended as well. It's very clear that it's useful in orthostatic hypertension, low blood pressure. And there has been a recent study that has shown, a small study though, that shows some benefit in PoTS. Most of the people who have PoTS are sort of younger women, and they often find the NHS style compression tights quite unacceptable. They are available on prescription, but there are some more snazzy, jazzy tights available to buy on the internet or in stores. Again, for men who are affected, they often find compression tights unacceptable, and sometimes prefer to use the compression sports clothing instead. And in fact, some women often find this preferable as well. There are postural manoeuvres that you can use to prevent feeling lightheaded or fainting. And these have been shown to raise blood pressure and to reduce heart rate in PoTS. And the sort of things that you can do are to cross your legs and squeeze your thighs and buttocks tightly, to elevate your leg on your knee when you're sitting, if you're getting symptomatic while you're sitting, or even just put one leg up on at a height, say on a step or a stool, can be useful. You can also squat down, and that can relieve symptoms, but you've got to be very careful when you squat, because when you stand up, it traps the blood in your legs, and you can suddenly become very, very symptomatic. But if your symptoms are getting very severe, then you've really got no choice but to lie down flat, maybe put your feet up in the air and get your legs to ride a bicycle. You can actually, you can use some of these maneuvers quite subtly. For example, if you're standing in a supermarket queue, you could just rock up and down on your toes, and that activates your calf muscles. Or you can sort of squat down and rummage in your handbag or tie your shoelaces if you feel uncomfortable about some of the other maneuvers that we've shown here. Patients find that not only do they overheat, but they're also very sensitive to warm environments. I would recommend dressing in layers so that you can take layers off as you need to and put them back on again. There are cooling vests available. They're not available on prescription that I'm aware of. I think you'd have to buy them. And the only problem with them is that you do have to freeze the fluid, and they can be very heavy. And sometimes a bit uncomfortable. There are sports towels available, and the cooling towels, you just soak them in water and wring them out, and they still feel quite dry, but you drape them around your neck or something similar, and as the water evaporates, they cool down your body. Now, sometimes patients are asked to wait maybe 3 to 6 months to see how the lifestyle manoeuvres improve their symptoms. And then if they're not significantly improved, then the medication might be recommended. And sometimes in more severely affected patients, the medication will be introduced at an earlier stage, because that will then, if they feel a bit better, that will then help people to be able to engage in some of the lifestyle measures, such as horizontal exercise, for example. When you're looking at medication, first of all, you want to try and remove drugs that would normally trigger symptoms. So that's the ones I mentioned before that drop your blood pressure or increase your heart rate. And then the medication that we use in PoTS is primarily designed to expand your blood volume, to narrow your blood vessels, or in PoTS to reduce the fast heart rate. And again, many of the drugs are based on medication that was used in low blood pressure or orthostatic hypertension. So beta blockers will slow your heart rate down, and they don't really know why they work in PoTS, but they think it might be because they allow your heart to fill up and therefore between beats, and therefore work more effectively, and they also narrow blood vessels, but the mechanism's really not clear. The problem with beta blockers is that they can lower your blood pressure, and so some people become much, much worse. So if people are prescribed beta blockers, they're often given them in a very, very small dose to begin with. Ivabradine works a bit like beta blockers. It works on something called the funny channel in your heart, and that is actually a medical term. And it slows down the heart rate without actually dropping the blood pressure as much as you would see in beta blockers. So certainly some of the clinics in the UK are finding Ivabradine quite successful, and patients are reporting that back to us as well. Midodrine narrows your blood vessels. Fludrocortisone expands your blood volume by making you retain salt and therefore water. Pyridostigmine, that acts at the nerve synapses. Desmopressin, that's actually a medication that's used in bedwetting. So children will take it at night and then they don't wee overnight, but you can also use it in PoTS, and it stops you going to the toilet as often, and therefore can help to expand your blood volume. But there is, well, with all these tablets, there are side effects, and with desmopressin, it can dilute your blood and drop your sodium levels, which can be harmful. So that either has to be monitored, or certainly more so in the USA, they tend to recommend it as a pill in the pocket medication. In other words, if you know that you're going to have a difficult day, or say you're having an exam that day or something, just take it on the days that you know are going to be more challenging for you, and then you reduce the risks of side effects. Octreotide, it's sort of an anti-cancer drug, but it narrows the blood vessels in your gut, and it's an injection, and is occasionally used. And clonidine, sometimes it's a migraine drug, but they sometimes use it in the hyperadrenergic type of PoTS. We're often asked about hormones in PoTS, and certainly some patients have exacerbations in the PoTS around the time of their period or just before their period. This is really an area that needs a lot more research. Some people have reported to me that they find that they're better when they don't have periods. And I certainly prescribed the mini pill in some patients, which has stopped their periods, and then their symptoms have got better. But there haven't really been any large research studies that can back this sort of treatment up. I quite often get asked about whether people with PoTS should have HRT after the menopause. And again, there hasn't been any research done into this. And I usually, certainly with my own patients, I would recommend that if they feel they want to try it, once they know about the risks and side effects, give it a go. If they feel better, great. If they feel worse, then you can just stop it again. There has been an increasing interest in regular intravenous fluids, initially in North America, and now we're getting quite a few inquiries about it here. Certainly in an emergency situation, if somebody's in A&E and their heart rate's racing, or they're dehydrated because they've got vomiting in pregnancy or gastroenteritis, then using IV fluids in that situation is often recommended by specialists. However, having it on a very regular basis hasn't been studied yet. There have been 1 or 2 studies, but they've not compared them to controls where people have fake infusions. So it's very difficult to assess whether this is helpful or not. And unfortunately, having a long-term indwelling line to be able to do this can have quite serious side effects. So this is something that really needs to be looked into further. For some people, cognitive behavioural therapy or other psychological therapies can be useful. It's sometimes quite a difficult subject to raise for patients, because if you remember, half of patients have been told that they've got some kind of psychiatric problem before they were actually diagnosed with their PoTS. And it's I'm not suggesting it should be recommended for that. Patients often have very scary symptoms such as palpitations and chest pain, and sometimes cognitive behavioural therapy can help patients to manage these symptoms better. It can also, you know, if you've always been very fit and healthy and you suddenly find that you can't do all the things that you want to do and you were able to do before, and if you're having difficulty adjusting to that, then some of the talking psychological therapies can be useful for some patients. Travel can be difficult for patients with PoTS, and there are some apps available, for example, you know, on the London Underground, that will help you to find step-free access to some of the stations and plan accessible journeys. And again, in London initially, and now more widespread around the country, there are offer me a seat badges and cards, and patients can wear these, and the idea is that somebody is meant to offer them a seat. I mean, I have used that because I really struggle on the Underground, and I do find that sometimes people, because you look well, really don't feel that they want to offer you a seat. And so also traveling on aeroplanes can be a challenge, and there are sort of relatively recently these sunflower lanyards were introduced by most of the airports around the UK, and these identify you as someone with a hidden disability so that the staff there can be more alert that you might need special support, or that they might need to take a little bit more time, or you might take a little bit more time. And we've had really good feedback about the lanyards, and also the fact that in the airports there's additional training of staff happening so that they're more aware of invisible conditions and what support people might need. However, if you do struggle in these situations, sometimes carrying a little portable seat around with you can be useful. And I certainly find I've got one of these, it just fits in your pocket, and I find that really, really useful on the Underground and other public transport when I can't get a seat. And similarly, there's sticks like this that they just fit into a little bag, and you can just whip them out if you're standing in a queue in a supermarket or something like that, and you anticipate you're going to have a problem. Regarding working with PoTS, you know, we do hear that a lot of patients experience difficulties with understanding by their employers. And so very recently, we developed this leaflet that you can give to your employer. It's been reviewed by an occupational health doctor who knows a lot about PoTS. And you can print this off our website and you can give this to your employer, and hopefully you'll find that helpful. So some people find that they struggle to have the sort of, to get a diagnosis or to get the care they need from either their GP or a local consultant. And it can be helpful to be referred to a specialist who has knowledge of PoTS. And this, actually, it's a little bit out of date looking at it, but this is a page from our website, and it tells you a little bit about where these people are and what age groups of patients they will see. It's particularly challenging in some areas of the country like Scotland, Wales, Northern Ireland or Ireland, and also the north of Scotland, of England, and for children there are very, very few specialists, and it's something that the charity is currently campaigning to try and improve. So how do you, you know, or what rights do you have regarding asking for a specialist referral? So if your doctor wants to refer you to a specialist, you can ask to be referred to a particular person or service, but there's a caveat to that, and that is if it's commissioned by the CCG. And you know, certainly in some areas there are no services commissioned for PoTS patients by the local CCG, which is very problematic. If the service is not available in your local CCG, and the local CCG, by the way, is a group of GPs who buy services on behalf of their patients. And if a service is not available, they or NHS England should investigate and provide a suitable alternative, although we know that that doesn't always happen as it should. Sometimes individual funding requests are required, and you can apply to your CCG, or they have different names in Scotland and Wales, but you can apply to these groups for an individual funding request, or your doctor can do that on your behalf. However, when you do ask for a referral, according to the NHS rules, that your GP is not obliged to refer you. They will only refer you if they feel it's clinically appropriate, which is obviously quite difficult when a lot of them don't know about PoTS. You can request a second opinion. You're not entitled to one, but again, you know, the NHS guidance says that it would be very unusual for somebody to be declined a second opinion. And sometimes, if you're having trouble getting a referral, you can ask the GP to look at NHS e-referrals, and if they can find the service that you're looking for on the e-referral system in the GP surgery, sometimes it facilitates getting your referral that way. However, when you do get referred to a service, you can't always guarantee, unfortunately, that you can see the consultant that you want to see. If things are going really very badly for you, you can give informal feedback, or you can make a formal complaint. And you can do that to the provider, that's the person who's providing the service, such as the GP, or if it's at a hospital level, you know, the hospital team, the manager, or you can even address it to the chief executive officer of the trust, the hospital, or you can refer it to the commissioning group, and that would be the CCG that I mentioned before, who are buying the services on your behalf. Or for specialised commissioning, that would be to NHS England. Unfortunately, PoTS was declined specialised commissioning in 2017. You can get help from the Patient Liaison Service at the hospital. Citizens Advice Bureau can sometimes be helpful, and there are local health watches and the Patients Association who might be able to either advise you or represent you. If all that doesn't work, you can apply to the Parliamentary and Health Service Ombudsman to have your complaint resolved, or in very serious cases, the regulatory body, such as the General Medical Council for doctors and the Royal College of Nursing for nurses. So how best to work with your healthcare team? Well, first of all, be as open and honest as you can, and don't put on a brave face, and try not to sort of overemphasize your symptoms as well. Try to prioritize what worries you the most. It might be necessary to take a list, but bear in mind that because of the time limitations, it might be that they can only address the top ones on your list at the first appointment. Supported self-management is the buzzword. It used to be just self-management, but supported self-management means that you manage yourself with the help of your healthcare team. So ask for help when you need it. Try to keep records of your appointments, and if you get copies of hospital letters, it's really useful if you can save them and share them where necessary, because a lot of correspondence goes missing, unfortunately, in the NHS. And then before you leave an appointment, just make sure that you know what the next steps are, what's going to happen next, and what you should do if your condition deteriorates. And also, you know, the NHS is very challenged at the moment, and so try to understand the limitations within which your healthcare team are trying to work. Okay, so that's the end of my talk. I'm just going to hand over to Jo for a minute, and she's going to tell you about our up and coming retreat, where you will be able to learn more and hopefully meet individuals with PoTS if you haven't met them before.
Thanks, Leslie. And thank you very much for that. That was great. If people, while I'm talking, if you want to add your questions to the Q&A box, then please do feel free to do so. So we've got our retreat on the 24th of October. It was originally due to take place in April last year and then was rescheduled to October last year, but obviously with COVID that's been cancelled. We're so looking forward to it. We're really planning on making it the best day possible, and for the first time we're offering it on a both in person, and it's at the De Vere Cotswold Water Park, or people can join virtually for the day if they would rather. So it's open to absolutely everybody. All of the I'll send an email afterwards with the slides and the link to booking the event and things like that. But it's just going to be a day full of really useful tips, a really great opportunity to meet people who are in the same boat as you. For those who are attending virtually, we'll still try and link you up so that you can chat with other people, and we'll try and make it feel like you're as in there as in person as we can. It's £15 for the online tickets and £35 for the day. And that includes the day ticket. If you're attending in person, includes food and everything. Within the Eventbrite page, there's a list of frequently asked questions. So have a good look through those. But if there's anything else, the email address is on there. So just get in touch with us and we'll answer any questions that you've got. But we hope to see lots of you there. It looks like it's going to be a great day, and we'll be sharing the agenda and things like that just as soon as we can. So thank you very much. Should we?
If it's for over 18s only.
Oh yeah.
At the moment, we will try to offer something for younger people at some stage in the not too distant future.
Yeah, absolutely. So yeah, 18 and over only. Okay. Right then. So some questions. Let's have a look. Okay. So Leslie, somebody's put, I'm having a lot of trouble with chronic dehydration. I can't seem to improve things with just salt and water. My pee runs clear, but I feel as though I haven't had water for days. Do you have any advice on this?
Well, first of all, if urine's running clear, then it's unlikely that someone is dehydrated, although there are some very rare conditions where this can occur. If the symptoms that you're feeling are due to PoTS, unfortunately in some cases fluid and salt just isn't enough to resolve the symptoms. I would say in this situation it might be worth discussing this with your GP or your specialist. Sometimes there are some tests like blood tests or 24-hour urine sodiums that can be helpful to clarify matters in this situation.
Okay, that's great, thank you. I know you mentioned salt during your the presentation, but how vital is salt to improvement? I cannot tolerate any due to gastric issues, even slow sodium.
Well, first of all, salt helps to keep the fluid within your blood vessels. So it is very helpful, but as has been mentioned, some people can't actually tolerate it for a variety of reasons. There isn't really an easy answer to that I'm aware of, and it might just be that you'll have to rely on some of the other treatments that we mentioned earlier.
Okay, thank you. My teenage daughter is awaiting a diagnosis of PoTS from a cardiologist after having tests. I wondered if you had any advice for dealing with brain fog. My daughter is in her first year of A-levels and is struggling with retaining information for exams, and I can see her stress levels rise, which obviously doesn't help other symptoms. So any advice for dealing with brain fog, which I know is a question we get asked a lot.
Yeah, I mean, really, until we fully understand brain fog, and I don't think the medical profession fully understands it yet, really the treatment is more about just maximizing your treatment for PoTS and you know, trying to prevent getting lightheaded and palpitations as best you can. It can be helpful when studying to study with your feet elevated. So some people might have their feet on a footstool or maybe lying in bed to prevent symptoms, and pacing the studies can be helpful. Try to keep stress to a minimum, and you know, techniques such as relaxation exercises, meditation, mindfulness, and cognitive behavioural therapy can be helpful with this. And that was a timely question, because we're actually in the process of developing a new page on the website for people who, well, we've got one for people at university already, but we're going to add one for specifically for people who are attending school or other forms of education before university.
Okay, thank you very much. Is it correct to say that PoTS is always a secondary condition to another? And if you can find the root cause of the other condition, you can heal or at least reduce your symptoms of your PoTS? Or is it that once you have a diagnosis, it's a lifelong condition?
So sometimes PoTS is associated with another condition, or possibly secondary to another condition, like, for example, autoimmune conditions, or it can follow on from a viral illness, or most commonly hypermobility. That's the commonest association that we tend to see at the charity. And so for some of these, although you can identify a cause for it, you can't always do something about it. In fact, sorry, can I just switch off my phone?
Yeah, of course.
So, I mean, people do report if they've got an autoimmune condition and it's treated, their PoTS gets better. But again, there's been small reports of this, but we haven't had any large studies to look into it in proper detail, the detail it needs.
Okay, thank you. I've got another one here that I find that I'm half awake all night and unable to sleep. When I wake in the morning, it feels like I haven't slept at all. So any advice on sleeping? I think that, again, that's a really common one that we get, isn't it?
Yeah, I mean, sleep disturbance is a very common problem for people with PoTS. And in fact, the definition, or one of the definitions of fatigue, is tiredness that doesn't resolve with sleep. And this fatigue occurs in around 90% of PoTS patients. I'm not sure the age of the person that sent in this inquiry, but teenagers and young adults do have a natural sleep cycle that means that their body wants them to go to sleep at a later time and sleep later in the day. However, unrefreshed sleep or poor sleep is a very difficult symptom to manage. There are some things that you can do to help. Obviously maximizing your management of the PoTS itself. Have a regular sleep routine and a regular bedtime routine where you can. Avoid using computer screens and phones and tablets in the evening, because they produce blue light, and this tricks your brain into thinking that it's still daytime. Avoid caffeine, and remember that that's in some fizzy drinks and tea and chocolate as well. There are some apps that can be helpful. We've had quite good feedback about Sleepio and the Sleep Station, for example. Regular exercise can help, but preferably done earlier in the day. If you do any exercise later in the day, it can affect your sleep. Try not to use the room you sleep in for your daytime activities, and don't nap in the day if that's possible. And all these things can train your brain to recognize that it's time to sleep and switch off. And then finally, sometimes CBT can be helpful, again, to retrain your brain into sleeping at the appropriate time.
Okay, thank you. Are purpura and vasculitis likely with PoTS?
They don't generally occur in PoTS per se on its own, but there are some conditions that are associated with PoTS that can cause vasculitis and purpura. For those who don't know what it is, purpura is bruising, and vasculitis is inflammation of small blood vessels. So, for example, in some conditions like autoimmune conditions or some types of Ehlers-Danlos syndrome, you can get both of these phenomena.
Okay, thank you very much. I think we'll do one more question now. I can see that we've had quite a lot come through. Please do rest assured we will answer your questions as best we can, and we'll come back to you with these. So don't worry if your question hasn't been answered, we will address it. The final one then, Lesley, if your heart rate only elevates above 30 on standing for 10 minutes at odd times rather than continually, and it doesn't happen on the day of the tilt test, is this likely to rule out PoTS when the majority of other PoTS symptoms are apparent?
Okay, so patients with PoTS can fluctuate a lot. So they can have good days and bad days, or they can have a good time of the day and not such a good time of the day. And so some of our specialists that we work with and speak through the charity say that if a patient has very, very typical symptoms and they have a tilt test or a stand test that's negative, then they may repeat it on a different day and hope that they get you on not such a good day, and they're able to capture that increase in the heart rate. And the other thing that's an issue is that the cutoff of 30 beats per minute is a very arbitrary number. And so, you know, some of our some patients have been told that, oh, your heart rate only went up 29 beats per minute, and although you've got very typical symptoms, that's not PoTS. But I think it's still got a long way to go, but increasingly consultants are recognizing this, and so some of them will say that you've either got PoTS or you've got a PoTS-like picture, and then go on and manage it as they would do PoTS.
Okay, brilliant. Well, thank you very much indeed, Lesley. Have you got anything else you want to add before we finish?
I don't think so. We'll obviously happy to share slides, and also we'll pop the video up on YouTube by the end of the week.
Yeah, that's great. So yeah, that will all be up on our YouTube channel. If you can do the survey when you close your link down, it will pop up. That would be absolutely fantastic. And I think if anybody is very new to PoTS, I mean, I think the first thing you do whenever you learn about something is you Google it, don't you? So presumably you will have found our website, but I would think we'd all advise to kind of really trawl through that. There's lots of patient stories on there that we get lots of feedback that people find really useful, reading about other people's experiences. So have a good look through, and we will be back in touch with you all with slides and videos and all of that sort of thing, and answers to the questions that we haven't managed to get through. So thank you everybody for joining, and take care. We'll keep you posted about future webinars. Thank you, Lesley.
Thanks, Jo.